So I'm Ksargeant and this is my cardioversion Osce. I've been called this afternoon to a 70-year-old male with cardiac chest pain and neck lapse. He explains that the chest pain is quite severe, acute in setting, unable to stand due to the dizziness and feeling unwell. He's got a previous history of myocardial infarction approximately 5 years ago and explains that this time the chest pain feels quite different. He says that the palpitations feel like that his heart's going to pop out of his chest. He appears pale, clammy, his eyes are opening to voice and he's mildly confused. On arrival, he's unable to obey commands. When we ask him to squeeze our hands, he can't. So he appears quite compromised and unable to obey commands. 70 in current VT, blood pressure of 70 over 40, very hypertensive, rest rate of 24, BGL of 7.6 and temp of 37. With this hypertension and his VT, it puts him in the severely compromised category for cardioversion. We now move on to assessing the patient, lying him supine and prepping for cardioversion. So we've got our patient lying supine on the ground. To confirm his rhythm, we apply a 3-lead. A 3-lead is applied here, and our monitor is telling us that he's in VT. His heart rate is over 170 and maintaining. We need to apply a 12-lead to confirm. We need to also confirm and rule out any differential diagnosis for why this patient might be in VT. We've conducted a temperature which is at 37. The potential of it being sepsis is minimal, but there is a possibility of being sepsis. Also, because it's a wide complex VT, we need to rule out potential SVT. The treatment will still be the same, but it might be with a variance. And the other things that we need to look out for as well is his reason for the lowered levels of consciousness or inability to obey commands. As he's unable to squeeze our hand, it also means that he is severely compromised, and the hypertension at 70 systolic is another indication is severely compromised. He doesn't appear short of breath, but we do need to actually check that and listen to his lungs and make sure that he hasn't got any other respiratory conditions which could be an indication of why he's gone into VT. He looks pale and clammy, which is another reason why he's high risk or potential high risk for any cardiac event. When we've got him lying here as well, we need to also conduct another set of observations, blood pressure, SpO2 and rest rate, and monitor that constantly. While we've done the 3-lead ECG, we need to also apply a 12-lead. For the purpose of this, I would have applied a 12-lead, but we're unable to with the mannequin. Once we've confirmed that he is severely compromised and likely to need cardioversion because he's in VT, we need to call for backup. So Alexandra 1 to control. Alexandra 1, go ahead. Requesting R50 for potential medication for cardioversion over. Yep. ICP backup coming. So due to the fact that he's severely compromised and unable to obey commands, the need for pain relief for cardioversion is not needed because he isn't able to obey commands. If he was able to obey commands, then we would likely need to sedate him for the cardioversion with ketamine, and that hence the need for an ICP backup. We can call clinical control and do it via phoning a friend if necessary, but best to always contact for backup if needed. So now that we've confirmed that the patient is needing to be cardioverted, we need to prep for cardioversion and prep the scene for cardioversion. So what we need to do is prepare the resuscitation equipment, ensure that the oxygen is working and efficient, that we've got a bag valve mask out ready to go, attached to oxygen at 10 litres per minute, obtain IV access. So we've already done that in our initial primary survey, and we've got that there in his right hand, and make sure that we've got any airway gear out that we would need. So we've got an LMA, because he's over 80 kilos, we've got a size 5 LMA ready to go with a 50ml syringe to inflate. We've also got the ETT tuber holder here and the suction ready to go underneath his head. The next thing we need to do is attach the pads, so we'll do that on the apex and sternum. So we need to put those on there and ensure that they're ready to go, and ensure the defibrillator is on manual mode. So once we put it on manual mode, and ensure it's on manual mode so that we can alter the joules as necessary. So we need to do what we need to do is sync the machine. So syncing it so that it's on the R wave, and confirm that it's on the R wave by printing a small strip and checking. So we need to make sure that the spike, or the syncing spike triangle, is actually at the tip of the R wave, because if we don't do it on there, we'll potentially put them into R on T phenomenon or into a variable rhythm, which we don't want. The next thing we need to do is discuss on the checklist is to discuss whether or not analgesia is appropriate. We've talked about that before, as he's unable to obey commands. In this instance, it's not necessary, but we've still called for R50 backup just in case. Next thing on our list is to select the joules and charge the defibrillator and confirm everyone is clear. So we treat this as we would shocking a patient in cardiac arrest. So on manual mode, adult dose. We've confirmed that the spiking is on the R wave. We need to charge to full joules, stand clear, shocking. Now, shock's delivered, and then we need to reassess to assess what rhythm the patient's in, and hopefully they've reverted back to a normal sinus rhythm with potential possible cardiac output that's adequate. If not, then we can actually reassess and conduct another cardioversion. With these MRXs and LifePak 12s, it's really important that you reassess whether or not the spiking and the spike and pacing is on the actual R wave itself. Otherwise, you need to resync the machine. And that's Cardioversion Osce. Hi, so I'm Ksargeant, and this is my RSI Assist Osce. This afternoon we've been called to a 40-year-old male who was water blasting his roof of a second-storey building. He slipped and fallen and landed on the back of his head onto his concrete driveway. His wife has come out to find him lying supine on the ground. She's called us and said that he has an isolated injury to the back of his head. On arrival, we've found that he has got an isolated injury to his occipital region with a 6 centimetre boggy patch to that region. He's lying supine and presenting as restless. He's having external rotation to painful stimuli with irregular respirate and grunting noises. His heart rate is 50, blood pressure of 160 over 110, a rest rate of 12 and quite irregular. His blood sugar levels is 7.6 and his temperature is 37. At this point, we confirm that he's got a severe TBI and we request an R50. Control from Alexandra 1. Alexandra 1, go ahead, requesting R50 for RSI. Roger, RSI backup will be 10 minutes over. Right, so at this point, when we've confirmed that he is severely compromised, both airway and a GCS of lower than 10, we need to prepare for RSI. And we've done that by confirming his GCS is 8 and that with his regular rest rate, and we need to maintain that airway and maintain his breathing. To do that, we need to make sure that we've taken a blood pressure. His blood pressure, as said before, is 160 over 110. With a severe TBI, we need to ensure that systolic pressure stays at least 120 systolic, and maintain his rest rate and really maintain that airway. To prepare for the RSI, we need to open our checklist. The checklist is on in a pocket edition of our CPGs, is on page 131, and preparation for RSI checklist. The first point of this checklist is to attach nasal prongs without oxygen. So we've done that on here. We've got him lying in a supine position with his sniff position to maintain his airway and keep his airway open. We need to pre-oxygenate using reservoir, bag or mask, manual ventilation bag at 10 to 15 litres with PEEP set at a minimum of 5 centimetres. We have got PEEP set here, ready to go at 5 centimetres of H2O, and we've applied the reservoir mask on oxygen at 10 litres per minute. We've already attached the blood pressure cuff and SpO2, and we're maintaining those and checking them regularly with our crew partner to maintain this, to make sure that the systolic pressure stays at 120 systolic. Prepare the capnography if this is available. So on this machine here, we'd prepare the capnography. At the moment it isn't available, but the RSI ICP will ensure that he has that in his kit on arrival. We need to position the monitor so it can be clearly seen, leaving space on the right side for the eye of the head for the intubation equipment. So I have got small LMA here ready in case his airway does collapse, and we do need to do an LMA in the meantime before the ICP arrives, but we need to make sure that this is nice and clear. So we'll get the bag out of the way, make sure there's room for the ICP to come in and do ETT tube and intubate. Gain IV access. During my first initial primary survey I conducted, I actually inserted an IV into his right hand here, and we need to get IV fluids running. So my lovely crew partner has set up IV fluids for me, and we need to attach those. We need to position the patient for optimal airway control. As I said before, we've done that, so we've put a towel underneath the back of his head and make sure that his head's in head tilt chin lift into the sniff position. Place the ETT holder with the strap undone underneath the patient's head. We prepped this earlier, but here is the position for it ready to go for when the ICP arrives. Ensure suction is working and turned off. This should be part of your critical checks, but when you come into the scene, you just make sure that it is ready to go. So the suction is fully operational, and that we've put the yanker handle underneath the left side of the patient's head. Prepare manual bag with PEEP as we done before, so manual bag's ready to go. Once they've placed the ETT tube, we'll move the oxygen over to the bag and place the ETT tube on there. Then we'd maintain and obtain another set of vitals, so we'd go through and conduct another set of vitals and ensuring we're keeping that breath rate up, the SpO2 up with proper oxygen saturations, and the blood pressure is maintained. Prepare the area. If the patient is not in the ambulance, clear the area so there's access to both sides of the patient if possible. If the patient is in the ambulance, clear away as much unnecessary equipment as we can. So on this point, we've cleared as much as we possibly can away from the patient and ensure that there is space for the ICP to conduct the RSI once he arrives. At times, intubation can fail. The first classification of a failed intubation is if you are unable to visualize the vocal cords within the first 15 seconds, or laryngoscopy is unsuccessful after 30 seconds. What will happen then is that the ICP will likely introduce a bougie, which is just a small piece of wire that they will insert into the airway and visualize the vocal cords, which is much smaller and rigid than an ETT tube. Once they've visualized the vocal cords, they will ask the RSI assistant to hold on to that in position. Then they will feed the ETT tube over the bougie. Other things that they could actually ask you to do is maintain or apply anterior tracheal pressure, change the blade of the laryngoscope, or reposition the patient. If that fails, the classification of a fail is if the end tidal CO2 is less than 5 millimeters of mercury after 2 to 4 breaths. If that's successful, we move on to the post-intubation checklist. If it's unsuccessful, then we need to remove the ETT tube, put in an LMA, OPA or NPA and continue to bag valve mask.